Okay, hi everyone. Again, my name is George Gatto, and I will be your host for this presentation of the presenters. My co-presenters are Amanda George, and she's from an organization called ETOS in Kansas City, and she will introduce herself when it's her turn to come on. And then also Barbara Wyman, who is a nurse and also has a training business called B&E Education, and Barb will also introduce herself. So today we're going to be just talking about developmental disability health promotion, and before I do that, I guess there's a couple of things. Oh, thank you. So is that better? Can you hear me better now?
That's better.
Okay, thank you very much. I didn't have my mouth right up near to the microphone. Anyway, so someone just preempted what I was going to say, but if you do have questions or comments, just put them in the chat box there, and we'll try to respond to them right away. Or if it's a question, maybe we'll hold some of the questions to the end of the presentation. And then the other thing is that I don't know how to mute people, so if you wouldn't mind muting your phones, or if you're on the actual online audio, then mute that as well. All right. Thank you again for all of those things. So I'm just going to start with some information that comes out of a report that we wrote in conjunction with the Bureau of Community Health and Wellness at the Department of Health and Senior Services. And so people with intellectual disabilities are at significantly greater risk for inactivity and related health problems when compared to both people without disabilities and people with other disabilities. And in Missouri, only 28% of adults with intellectual disabilities engage in moderate physical activity for at least 30 minutes 3 times a week. Inactivity and poor nutrition lead to health consequences that make it more difficult for people with disabilities to participate in community life. And also, given the well-documented risk of social isolation for people with disabilities, and established links between physical health, emotional and mental health, and quality of life, the need to make public health programs more accessible and inclusive becomes very compelling, and it's what we're trying to do with this project. And so let me tell you a little bit about this project. In an effort to address these situations or the circumstances I just outlined, the Bureau of Community Health and Wellness at the Missouri Department of Health and Senior Services is collaborating with my organization at the University of Missouri, Kansas City, and we're called the Institute for Human Development. And the idea is to promote health or inclusion of people with developmental disabilities in public health programs around the state. And this is a project that is funded by the Centers for Disease Control and Prevention. Overall, what we're doing this year is providing a series of webinars, and this is one of them that will hopefully, I guess, just give you some information that you might need to make programming accessible, and also help you to identify people that, if you have questions, that you can talk to. So with that, I'll move into the presentation. So this program or webinar and the information that we're going to present was originally made possible through some funding from the Health Forward Foundation that was provided to ETOS and to the Institute for Human Development. And then we partnered with the BE Education Group, and then we have for the full training, it's a 12-hour module, and it's specifically directed to people working with individuals with intellectual and developmental disabilities. And generally, the people who participate in the training are caregivers, care coordinators, family members, and community health workers. And so today is a summary of that 12-hour module. If you in your organizations think that you might like to participate in the full 12-hour module, then please feel free to contact me or either of the other presenters. Is someone asking a question? I'm sorry. Okay. Again, I guess I just ask if you wouldn't mind muting your phones, that would be great. Thank you. So I mentioned that Amanda George is one of my co-presenters, as well as Barbara Wyman, and they will introduce themselves in a minute. And my name is George Gatto. And so the overall objectives for the webinar then are to discuss the causes of disabilities and effects on quality of life, identify the top 5 chronic illnesses experienced by individuals with intellectual and developmental disabilities, discuss some of the disparities related to services and resources for people with intellectual and developmental disabilities, describe some ways to implement goals towards healthy eating and physical activity for chronic illness, and then discuss effective and respectful ways to relay information when working with people with IDD and their family members. So just to give you a little bit of background, I want to just quickly talk about the etiology of developmental disabilities. And really what we're talking about is just a study of cause. And I want to talk a little bit about some of the factors that contribute to the occurrence of developmental disabilities. And then just mention that once the reason we want to know about the etiology is because then as health professionals and service providers, we're able to determine, how the disability resulted, and then take appropriate steps to ameliorate any issues that result as out of the disability. So basically, when we're talking about developmental disabilities, we have, as you probably all know, there are some genetic factors that lead to a developmental disability, and then there are also some environmental factors. And really, part of this whole program is focused more on those environmental factors. In our work, we are not medical doctors or researchers, and so we aren't able to do much related to genetic factors, but we can begin to address any environmental issues that either cause or exacerbate the consequences of a developmental disability. So just quickly, as background, we have the genetic factors. Those generally we have 2 or 3 levels of genetic factors. The first is the monogenetic disorders, which are caused by a mutation in a single gene. And so you may have heard of sickle cell disease or cystic fibrosis, Tay-Sachs disease, and there are many others, but those are all examples of monogenetic disorders and examples of disabilities that you may encounter in your work. Then there are these multifactorial inheritance disorders that are caused by a combination of inherited variations from the parents. So it's multiple genes acting together with environmental factors. And so that, again, I just want to point out the importance of the environmental factors. They really can have a big impact on a person's disability. And then we have, I guess the example of this is a learning disability or mental illness. Lastly, we have chromosome disorders, and these are caused by an excess or deficiency of genes that are located on chromosomes or by structural changes within the chromosomes. And the most common that most of us are familiar with is Down syndrome. Okay. So this is just a little bit of information. Um, so genetic factors or genetic causes of developmental disabilities can be inherited, or they can just be spontaneous through gene mutations. And just one thing that I thought was interesting is that they've identified more than 7,000 different genetic disorders in the human genome, and about 1,200 of those are associated with cognitive disabilities. Some of these are syndromes or a set of symptoms that occur together. This is just a slide. Hopefully you can see it okay. But this just gives you a list of some of the most common specific genetic intellectual disabilities that you might encounter with some basic information. Did someone ask a question? I'm sorry if I missed that. Okay. So here is where I really would like to focus, and that is on some of the environmental factors. And general environmental factors include a broad set of circumstances that can result in or contribute to disability. And examples might include low socioeconomic status. And for those of you who don't know, people with developmental disabilities experience are some of the poorest people, socioeconomically in our country. Poor nutrition can often lead to or exacerbate developmental disabilities. Substance abuse, lack of intellectual stimulation, poor medical care, stress, and parenting issues. There are prenatal causes, perinatal causes, and postnatal causes of developmental disabilities, and I'll just talk a little bit about some of those. Here is a list of prenatal causes. So these are things that happen, as I'm sure you all know, before the child is born, and things might can include prenatal malnutrition, folic acid deficiency, etc. Maternal behaviors and exposures, most commonly maybe is alcohol abuse. The perinatal causes are things such as asphyxia at the time of birth, and intrauterine infections also. And then the thing that we really, in our field have maybe the most, that we have the greatest possibility of impacting, those are the postnatal causes. Head trauma might be one. So this is, I think, a really important stat. 52% of postnatal intellectual disabilities are caused by head trauma, whether it's falls or vehicle accidents or abuse. And then we have other things such as near drownings, strokes, etc. You can see the list. One thing that maybe I didn't mention was that we can send you copies of this, and we are also recording this if you want more information about anything that you hear today. So why is it important to understand the causes of disability? Because certain disabilities are caused by inborn errors of metabolism and can be prevented. So I'm sure you all know about PKU and congenital hypothyroidism, and screening in a case such as that can lead to rapid intervention that either prevents or certainly lessens the impact of the disability. If a cause is inherited, families have a right to information so they can make an informed decision about what they're going to do when their child arrives and what their what course of treatment or what actions they may want to take. And then some developmental disabilities result from environmental causes, as I mentioned, and these are things where public health programs can really have a strong impact. In the absence of preventive measures, various approaches can improve an individual's quality of life. Intensive behavioral intervention, for example, is one thing that happens. Individuals who experience deafblindness can acquire language through specific early interventions. And then, we should have put it on here, but also just proper nutrition and exercise can also improve outcomes for people with intellectual and developmental disabilities in terms of their overall health and their overall quality of life. And then lastly, knowledge about causes can lead to development of better interventions and treatment, and in some cases, prevention.
Where do you see her?
All right, now I'm going to turn the microphone over to my colleague, Amanda George. So here is Amanda.
Good morning, everyone. Would you let me know if I need to speak louder or if there are any difficulties in hearing? Just type in your chat box. We are monitoring the chat box as we go through. And again, if you have any questions, go ahead and type those in, and we'll be sure to get to those at the end. So this section is Disability 101, and George did a great introduction for me. I work here in Kansas City and have worked in the developmental disability field since 1990. So I've done all of the different roles you can in the system, direct support staff, worked at the state. Now I work for a county organization. So we'll get started with one of the most important things to think about when we're talking about supporting people with developmental disabilities is social capital. And it's a pretty abstract term. I don't know if you're all familiar with it. I'll just do a brief overview of what social capital is and then how it impacts people with developmental disabilities. We know that social capital is a set of relationships and social structures. And these relationships are actually items that you can bank and use to improve your social standing, improve your life, and improve kind of your goals, achieve your goals in life. So it's all about who you know is a really simple way to define social capital. So when you have a variety of relationships in your community, you have more connections across your community, and you know more people, and you're investing in those social relationships, and that yields beneficial returns. Think for a minute of how many of you have gotten a job because of who you know, or you helped someone get a job because of who you know. Very similar, very simple examples of social capital. So what we know is that people with disabilities often spend all of their time with other people with disabilities. Oh, we're getting some background noise. Please, if you could mute your line, that would be great. And our system of supports is funded by Medicaid and is really working to change the service system across the whole nation, including Missouri. So we're really looking to create more inclusive programs for people with disabilities so they don't spend their entire life with only other people with disabilities. Because what that's created is a really small circle of relationships, and it's cutting people off from community relationships. So the more relationships and diverse relationships a person has, that can increase the overall health and wellness. And that's pretty common for all people, not just people with developmental disabilities. I wanted to talk for just a minute about health disparities. George mentioned these earlier. And just to point these out, we have worked here in Kansas City for about 6 years and have had a variety of grants and projects funded through our local healthcare foundation. So we've done a lot of research and lit reviews to find out the details and the stats about people with intellectual disabilities and health disparities. So we know that As George mentioned, adults with intellectual and developmental disabilities engage in low levels of physical activity, eat unhealthy diets, and have high levels, therefore, have high levels of obesity and then chronic disease. And because of the disability, they also use more health resources than the general population and receive less preventive health care and are less likely then to access health promotion programs. There are barriers that people with developmental disabilities experience, and many of those are similar to other people who are of racial and ethnic minorities that have been marginalized. The majority of people with disabilities experience poverty, abuse is a chronic problem, and lack of support. In addition to those above experiences, people with disabilities also experience limited access to healthcare and resources. And you see that that can be because of provider training. So when you look at where people with developmental disabilities live, most of them live at home with their families. And their families rely on their primary care physicians to care for their family member. And doctors, nurses, nurse practitioners may not have training in addressing the unique health issues for people with intellectual and developmental disabilities. In addition, stereotypes about people with disabilities, and because of experiencing poverty and because of the lack of support, many people don't have access to community activities, or if they do, some of the information and materials given in programs or just in general healthy literature aren't appropriate formats, not in language that's understandable or not provided in ways that people can access if they have a vision impairment. So here is a slide that captures the concept of health equity. And I like showing this slide because it includes a person with a disability in the graphic. I'm sure you're familiar with these visuals, but I'll just talk it through just to make sure. So the left side of your screen shows the concept of equality. The intervention that's being provided is equal. And when we talk about equity, we're individualizing the support that's provided to what the person needs and making it very person-centered. And that's
I'm on this, but she's showing
in the developmental disability field. So you see that one person doesn't need help to see over the fence. The woman there does a couple of boxes, and then the person who uses a wheelchair has a ramp. And
can we
equity
jump
takes
in?
into consideration all of the needs of the individuals to access the community and the resources available. The next part of our this sounds like somebody put us on hold instead of muting. I'm going to start a video for you. That's on YouTube.
I did that.
Just a moment to pull up. And it'll start playing. I'm not sure if you can see this video. Okay, sorry about that, folks, but you can see the video. The link you'll get available to you on the PowerPoint. What the video was going through. Sorry, technical difficulties. One moment. Okay, there we go. Sorry about that, folks. All right, sorry about that. It's a great video. What it represents is people with developmental disabilities riding a bus through town, a public bus, and the thoughts and the actions of people also on the bus. And those you heard initially were rather negative in the perceptions that people had of people with disabilities. So we're going to talk a bit about our language and how important that is to promoting empowerment and inclusion for people with disabilities. So what is People First Language? People First Language promotes that people with disabilities are first and foremost people who have individual abilities, interests, and needs. They're moms, dads, sons, daughters, brothers, you name it. They have lots of roles in the community. And the point of this slide is to point out how we are more alike than we are different. Just because of a disability, there are many things that we all share in terms of relationships. In America, there are about 54 million Americans that have a disability, which is 1 out of every 5. And as we know, people with disabilities enrich our communities. They are here. And in Missouri, we are estimating about 65,000 people in Missouri have an intellectual or developmental disability. People First Language emphasizes the person, not the disability. So when you're actually referring to or speaking about people with developmental disabilities, you're including the person first. And when you do that, the disability is no longer the primary defining characteristic of the person, but just one of several aspects. People First Language is important because it's an objective way of acknowledging and communicating and reporting on disabilities. It eliminates generalizations and stereotypes by focusing on the person first rather than the disability. Another way to think about person first language or people first language is to think about inclusive language. What is the language that will include the person rather than separate them? So when we think about disability, we all need support in some aspect of our life, yet we don't ask to be defined by the support we need. So if someone uses a wheelchair, we want to avoid saying that person is wheelchair bound. We would want to focus on that they're using a wheelchair for mobility. You don't want to refer to a group of people that use wheelchairs as the wheelchair people or all being wheelchair bound. They are all people who use wheelchairs to get around. Hopefully you can see the difference there. We also prefer to be called by our name rather than a label that separates us or makes us fit into a category that others define or prescribe. So for instance, referring to a woman whose name you know, you would not want to say, oh, she's a Downs person or she's a Downs. You would simply want to refer to her as Sally. Here are some examples and a link also that you can use to find more examples. So for instance, we would want to say a person has a disability rather than the person is handicapped. You may not be aware of the origin of the word handicapped, but it comes from ages ago in some third world countries. What still happens is that people with disabilities would sit on the corner with their cap in hand and be begging for handouts as a way of surviving. So it definitely doesn't have a positive connotation or an empowering connotation. If you come across a person who doesn't use words, you would want to refer to them as a person who doesn't use words to communicate, or you could include the mode with which they communicate. Perhaps they use a tablet, sign language, those kinds of things, rather than using references to being mute or dumb. Also, having a disability doesn't mean that the person is suffering or a victim of. It is just another part of their experience. So you would want to say a person has or a person has been diagnosed with, rather than saying a person is afflicted with, suffers from, or a victim of. So here's an etiquette quiz. So imagine that you are running one of your public health programs, and a person with Down syndrome is participating, and they're asking you about your organization. What should you do? So it's pretty obvious multiple choice answer here, but this is getting back again to that video of, you may not have a lot of experiences in working with people with developmental disabilities. So you may not be sure what to do. So the first question there says, look around for the caregiver and talk to them. That is one option. Another option is smile and ask the person's parent to call you. Another option would be look away and act like you didn't hear the person. And D is, of course, the most respectful way to respond to the question, and with the same information you would provide to a person without a disability. So part of the etiquette around this is we're not assuming that because a person has Down syndrome or has a disability that they can't understand what is being said in basic communication. The most empowering thing is to respond to the question just as you would with anyone else. So the kind of take-home point around People First Language is that our words and the meanings we attach to them create attitudes. They drive social policies and laws. They influence our feelings and decisions and affect people's daily lives. How we use words really does make a difference. And we'll notice that as in history, if you want to look back and see, in the 70s was the first time we had some real legislation around people being able to attend school with IDEA, the act that made it so that people would receive free and equal education. Then in 1990, we had the Americans with Disabilities Act, which made it easier for people to work and participate in the community and have access to places through accessibility accommodations being put in place. So this graphic represents the history and a bit of where we are today in terms of people with disabilities in the community. All three of these situations exist today in our community and in Missouri. And I'll give a couple of examples of those as we go through. So exclusion, you see that there are people around the circle who aren't allowed in to the main circle there. Exclusion exists and did previously when almost all people with developmental disabilities were placed in institutions, a few of which are still open today and still have people with developmental disabilities living in them. And the purpose of this was to protect the community and also to protect the people living in the institution. And we've come to learn that it is possible for people to live in communities and that we can provide more supports to make a more inclusive community. So segregation is still a way that services are provided to people, though we have moved away from a lot of the segregated services. You may, for instance, be aware that Missouri has state schools that provide kind of a separate but equal education for children outside of a regular, typical public school. This isn't saying those state schools are bad. They are very helpful and provide essential services to children with disabilities. However, other states have been able to figure out how to provide inclusive education so that all students are in one school. So it's something that Missouri continues to work on. In addition, work opportunities for people with disabilities in Missouri are still provided in segregated ways. We have sheltered workshops in Missouri that are only for people with disabilities to work. Not all of the employment opportunities are competitive paid employment in the community. And integration we see as a more inclusive approach. This is a large amount of our services in Missouri are still at the integration stage, where you may have a group home of 6 or so individuals with intellectual disabilities and developmental disabilities living together in a regular neighborhood, and that's great, part of the neighborhood. And classrooms are integrated. You may have heard of the class within a class, where a group of students with disabilities will join a regular class. All of these things are definitely steps in the right direction as we learn and grow. And this is where we're headed, knowing that we are better together when we can include all people in our community and moving towards inclusion. So the important work you're doing in the public health sector is just vital to promoting inclusion for all people. And thank you for your work. Just have a quick exercise here to think about where we've come and where we're headed. So depending on who's on the call, think about the decade you graduated from high school. So as I've been doing this exercise for about 15 years, and I've had to take off the 40 from my span of graduation. So for instance, if you graduated in the 80s, kind of right in the middle, think about your experience of the 80s. In terms of people with disabilities, where were they? Where did you see people with disabilities during your time? You may have seen them at school. You may not have seen them at school. You may have seen people working in your community. Usually we start seeing that more around the 90s or in this century, the 2000s. What did you experience in school for people with disabilities? Did you have people in class? Did you know that there was a classroom for people with disabilities, kind of usually back down the hall? Maybe you saw them at lunch. Or were people just absent? Usually by the time we get to the 80s, people are definitely seeing folks with disabilities in their school and their community. Perhaps you had a family member or have a family member that has a developmental disability. So maybe you had regular opportunities to be with people and have close relationships. So think about when you were in high school, and what were your thoughts and feelings about people with developmental disabilities at that time? Were you unsure of hanging out with people? Did you see people getting teased, and did you feel sorry for them? Did you see bullying? Again, were you a family member, so it was just Uncle John or Aunt Sarah or Cousin Tim, so it really wasn't anything different than a family member. And what were your personal relationships, again, with a person with an intellectual and developmental disability? And we find that since we have had this history of exclusion and segregation, that the majority of people haven't had a chance to have a personal relationship with someone with a developmental disability. And when you don't have those kinds of interactions, you don't really know people and know anything other than what the values maybe you were taught at home or you learned. So things have really changed from graduating from high school in the 50s, 60s to now, when people I have in class are saying, oh, Well, yeah, we had folks in class, and then we were friends, and maybe we even had a peer mentoring relationship. So we're really moving forward in the country, and I think that's a great thing. And a lot of that has come from legislation changes and attitude changes. Okay, so thank you for your time there. I am now going to turn it over to Barb Wyman for the next section.
Thank you, Amanda, for the history and person-first language. And when we think about healthcare, that is going to be very, very important in the programming that we do. My name is Barb Wyman, and my background is in nursing. I have had lots of years in the nursing profession, seen lots of changes. But I also have worked in the hospital and outside of the hospital, and my love for community and public health nursing is probably where my passion lies. I've done some work with community health workers and currently teach a community health worker course, so that some of you may be using community health workers in your programs. Hopefully this will be a little bit better for speaking. Okay. We're going to go through some of the chronic health issues that advancing the slides. Hold on for just a second. Okay. Thank you. When we look at chronic health issues related to our intellectual and developmental disability community, we see overall poor health and less access to adequate health care and more smoking and physical inactivity. A lot of these are prevention programs that we have tried to look at and figure out. Our overall poor health sometimes is attributed to more dual and chronic health issues, one compounding another, and there is less adequate health care. Access sometimes is a challenge because of different specialties that a person needs to see and be involved in, and sometimes we look at healthcare as one more doctor's appointment that we have to go to. And so sometimes we make decisions, and it's not always the right one or the best one. When we look at substance abuse, smoking, physical inactivity, some of that is our accessibility in our communities. And so we need to really take a look at how we've designed our accessibility for people who that need special, maybe ramps, maybe doorways, different programming. Okay. So this would be something that we need to kind of stay on top of and think more about. Advancing. Is it not working? We can just go. We're on secondary. Okay, examples of secondary conditions. Specific types of disabilities like spinal cord injury or other physical or mental health conditions can predispose a person to secondary conditions. And some of these secondary conditions we see in everybody, but pain is one. Depression, anxiety, substance abuse. There's a high rate of depression, sometimes because they are frustrated, they're anxious. Getting out into the community can sometimes be a real process from the time they get up in the morning until they actually get to where they are, and this causes some anxiety. Bowel and bladder problems, fatigue, overweight and obesity. Infections, pressure sores or ulcers, and other respiratory kinds of diseases or infections. One of those we're going to be talking about is aspiration, which causes some respiratory issues along the way. Arthritis or muscular atrophy due to musculoskeletal disorders is a priority that we need to address and see. Sometimes it's prevention, sometimes it is also teaching people pain management, how to deal with their arthritis, making sure that their activity level is up. And again, diabetes, and we see this in our general population now at even higher rates. So when we talk about some of the things that we do and are concerned about, we have to remember also that verbal communication may be a challenge. And sometimes our individuals have a difficult time expressing how they feel and maybe express signs of nervousness and anxiety in different ways through behaviors. Some of the symptoms of depression also can be related to how they deal with social activities, and sometimes they become more withdrawn, just like all of us do when we're not feeling up to speed. We kind of withdraw, come back within ourselves. So it's important for family caregivers and those of us working with individuals on a regular basis that we notice changes in their behavior. And sometimes these are very subtle changes, but very important changes. And remembering that change in our daily routines causes all of us anxiety. Some of us don't mind the change. Others of us have a hard time when things pop up or change, and so we need to keep that in mind. So when we look at obesity as an epidemic for people with disabilities, we also have to keep in mind that body image is very, very important, and that children and adults with mobility limitations and intellectual or learning disabilities are at a greater risk. About 20% of children 10 to 17 years who have had special care needs are obese, compared to about 15% without special health care needs. Our annual cost for caring for obesity related to disability is estimated at $400 billion. So when we look at health care and access, we're trying to close that gap as we look forward. Changing challenges facing people with developmental disabilities. Some of these are really health challenging issues. Difficulties chewing or swallowing food. This could be instrumental in causing aspiration pneumonia. Medications contributing to weight gain. Many times when we have multiple chronic health conditions, the medications contribute to the weight gain or they interact with each other, and it takes a while to get everybody facilitated and on an even keel with medication dosages. Physical limitations to exercise. We're getting much better at this. We now have shared yogas. We have a variety of exercises that can be done with limitations, physical limitations. But we still need to pay attention to what works best for some individuals. Pain is always going to be an issue, and this is something that if it's chronic or if it's just according to maybe an illness that they currently have, and how we teach and deal with that is going to be important. Lack of accessibility environments for exercise. Sometimes we have to kind of take a closer look at what is available. We're saying, oh yeah, we have this, but can everybody access the physical facility, or is there something that we can do to promote exercise at home on a regular basis as well? Lack of resources is always an issue: money, transportation, social support, but we know that this is very, very important to try to figure out a way to include all of our community members. Family stress. Families have lots of stress today anyway, but when we crowd appointments and schedules and we're caregivers, it takes a toll, and so some of this comes through in terms of behavior. Keeping in mind social isolation and technology devices in lieu of exercise is prominent in our society today. So this is something that's ongoing no matter whether we have a disability challenge or whether we're just normal teenagers or adults. The Fatal Five, Karen Green McCowan has done a lot of work in the intellectual and developmental disabilities realm and refers to top 5 disorders linked to preventable deaths in either care settings or in community-based, either residential settings or in home environments. So top 5 conditions resulting in deterioration or death of persons are bowel obstruction, GERD, aspiration, dehydration, and seizures. We're going to talk just briefly about some of the complications and challenges. Aspiration is the most common cause of death, and it's in the institutional settings, nursing homes, and large group care settings for persons with IDD. And we referenced before that some of this is aspiration pneumonia, so they may be hospitalized because they have aspirated liquids, because maybe they're drinking out of a straw all the time, talking with their mouth full. These can begin very subtly but can cause lots of damage to the lungs. Aspiration pneumonia is common diagnosis following hospitalization, so it is one that is preventable but may involve speech therapy and strengthening of muscles in your throat. Factors leading to poor body position. Sometimes people with a disability have a hard time sitting in a certain position for very long. Body spasms, behavioral issues, and related to eating are some of the causes. Gastroesophageal reflux disease, or GERD, is backing up of stomach contents, and sometimes it's undiagnosed in a lot of people and can do harm to the bottom of the esophagus. By the time we realize that this is a really big problem, again, related back to communication of symptoms and things like that, it's very difficult sometimes to diagnose. Overweight people carry weight around their abdomen and wear clothing too tight or have a greater risk of GERD. This also is dependent on positioning and how easy a person is able to sit or stand or move. If there's no treatment, of course, we have aspiration, GI bleeding, and esophageal cancers can occur. Bowel obstruction is another big issue. Most important root cause is the use of multiple drugs with constipating effects. So we have to constantly take a look and see how these drugs are interacting, if the dosage is right. Dietary habits also, low fiber and adequate fluids are a major concern for all of us, actually. Adequate active movement or exercise is important. Training caregivers to recognize signs and symptoms of bowel problems. So again, sometimes this is in behavior because it's difficult or a challenge for them to actually communicate what is happening and what they're feeling. And we do have to be careful of a high incidence of repeat episodes. Dehydration is a contributing factor to this. Individuals who do not swallow well are likely to refuse or indicate fear when taking fluids. Staff or family members may be restricting fluids to prevent incontinence. Medications given have hydration characteristics, so sometimes we have to drink more water or drink more of something or be very cognizant of how much our intake is. Fluids are the same, flavor, no flavor. Who likes always to have the same flavor of any drink? And so we need to kind of mix it up just like we do for all of us. Seizures is another big concern. Sometimes these occur due to drug toxicity or uncontrolled conditions. We always need to be aware that when you are working with staff, no matter where they are, who is teaching or being taught the protocol for dealing with a seizure. And this is something that we need to do for family members, for caregivers, as well as our staff in everyday situations. Life expectancy for persons with active seizure disorders is approximately 10 years less. So sometimes the seizure control is a real issue. Dealing with dental and oral health. Of course, we know that our dental and oral health is a big issue for all of us. It affects the health and well-being in a person's life, especially people with IDD. And sometimes difficulty in brushing, swallowing, getting the right toothbrushes. Also finding access to care, finding a dental provider who knows how to work with different disabilities, and choosing the education that is right for our intellectual and disability community members. Lifestyle behaviors affect good health, so tobacco use, medications, just general oral habits, oral diseases and conditions associated with other health problems are heart disease, and we're finding this more and more that it has a direct correlation. Routine dental screenings are very important, and having access to preventive dental care, wait lists, sedation, and just lack of working with the IDD community is of issue. Okay, so what can we do to be accessible? Relationships are important for people with ID. This is something that participating in community programs without someone to take them to the site may need support during the activities, so including family members, caregivers. People with ID cannot benefit from programs if they have difficulty understanding the materials, so make it simple, easy, fun when we talk about designing the programs and reaching the spectrum. Training for staff and volunteers is important, and going back again to person first and inclusiveness that Amanda referenced are very, very important. Outreach and information placement strategies influence participation of people with ID, targeting family members, partnering, pulling in the right people to help you with the programming and being inclusive as a public health. Including the neighborhoods is also very, very important. And then the last thing is to advocate. Always be the advocate. Think, how would I maneuver this program or this facility if I had a disability of some kind? Okay, I think we're going to transition over to Amanda and talk about other considerations for people with IDD.
Okay, we'll be wrapping up here. Thank you so much for your participation today. I just wanted to go through quickly a bit of what Barb just covered. The common learning difficulties that people who may be taking your programs experience are learning at a slower rate. They may have some communication issues. They don't read or write as well. And abstract thinking and comprehension is challenging. Also, they may have trouble with generalizing or relating ideas to their own life experience. So here are a couple of strategies you can use in reinforcing what we all like, having it be fun and practical. When we change our programs to work for all people, it always seems like people benefit. So again, here's 5 tips. One of the key things that may be different from your other programming is looking for that caregiver or direct support staff to be present. Almost always people will come with someone to help them, or there may be a few people coming with a caregiver. Those caregivers can be instrumental in helping apply what you're teaching directly to the folks. Also, wanted to point out that mental illness for people with intellectual disabilities is a common occurrence. So another one of those issues to be aware of. The comorbidity of an intellectual disability and a mental health issue is 2 to 3 times greater than the general population. So as a result, because of mental health issues people experience, there can be many reasons for those. Statistics and studies show that really anywhere between 70 and 90% of people with ID experience violence throughout their lifetime. If you're interested in learning more about this, Joe Shapiro last year did a special series with National Public Radio entitled Abused and Betrayed, and it takes you through some of the life experiences of people and some strategies that we can implement to help prevent the abuse and violence people experience. Because it is such a prevalent experience of people, we've included a few ways you could identify trauma that people have experienced and abuse. You may see anger, aggression, crying. Those may all be signs. People may see you or people in your programs as a trusted person, so they may share with you about their traumatic experiences, their physical complaints, and really any change in the usual. So if you're getting to know people through your programs and you notice something changing about their health or their mood, feel free to ask questions and look a little closer at what may be going on. The last thing to share with you today is talking about specifically people with Down syndrome and Alzheimer's. Just wanted to make you aware that more than 75% of people with Down syndrome, age 65 and older, have Alzheimer's disease, which is nearly 6 times the percentage of people in this age group who don't have Down syndrome. People with Down syndrome will, really see personality change and memory, have behavior changes more often than memory loss and forgetfulness. There may also be some memory loss, but you will see other changes. So if you're working with someone in your programs in their 40s, early 50s, and because of your experience in public health, you're thinking, interesting, that sure is looking like dementia or Alzheimer's, you might actually be working with someone who is experiencing that. So just wanted to put that out there for your awareness. And with that, that's our last slide. We are taking questions. Please feel free to take a minute or so and type in any of your questions you may have. You can type in, or it looks like Christy is going to unmute if you would like to ask those out loud. So if you have any questions, feel free to ask. If there aren't any questions, then we'll wrap up the webinar. Thank you so much for your participation. If you have any questions, you can reach out to and we can help you out with that. Thank you all. We will be providing a handout. We'll get that to you through the usual means.